So this is a 75 years old female, and she presented with the extensive anterior wall MI, severe elbow systolic dysfunction. On ECG there was a 1 AVL, V1 to V5, V6. There's a ST elevation, and after 4th, 5th day she has come, and this is the angio. You can see right from the ostial LAD there is a total thrombotic occlusion. In this RAO caudal view we can see whatever we are able to see, that is a diagonal, and there is a osteoprox thrombotic total occlusion in the LAD. In these still images near the arrow there is a total thrombotic occlusion, and whatever you can see, that is diagonal. Here in this cranial view we can see just above the arrow there is a total thrombotic occlusion in this cranial view. Again, this was the RAO cranial view, and you can see the total thrombotic occlusion. Patient presented after 4 days of chest pain. This was the RCA, fairly normal, dominant. So after all clearance, we took up the case. This is a right radial root with XB3. She was a thin female, 75 years old female. So I was trying to put the wire in LAD, but wire was going into the diagonal, and this is wire is in the diagonal. So I kept one wire in diagonal, and I took a second whisper wire. This was a run through wire, and I took a second whisper wire, and I tried. In this yellow caudal view we can see clearly this wire is in the diagonal, and there is a stump in the LAD. That was a very hard stump. After 4 or 5 days she has presented, so fairly organized thrombus. So in this scene, one wire, run through wire, is in the LAD, is in the diagonal, run through is in the diagonal, and there's a second wire I'm trying to screw, and I'm trying to rotate the wire in the LAD, and wire buckling was there. It almost took me 15-20 minutes. In this scene you can see clearly this one wire is in the diagonal and the second wire is in the LAD, but wire was not progressing. See how the wire was buckling and is not getting lesion crossed in the LAD. Then what to do? After about 15-20 minutes I took a balloon. It was an N balloon, and I tried with the balloon, but there was a long way to go. And somehow after trying, the balloon went, and this was the balloon daughtering. Balloon daughtering is a to and fro motion of the uninflated balloon, so that we can get the flow, in the hope of we can get the flow. But even after the balloon daughtering there is no flow. You can see wire is in the LAD. I confirmed wire is in the LAD with the different orthogonal views, but there is no flow. Then again I did the balloon daughtering 3-4 times, and then I did the multiple balloon dilatation sequentially in the LAD. This was 2.5 balloon, and even after balloon dilatation there's no flow. You can see mild minimal flow is there. With all try we got flow. You can see the flow is there in the LAD, distal LAD. There was very tight lesion in the proximal LAD, mid to proximal LAD. Then even again I did the balloon dilatation with the higher pressure. We went RBP pressure, and now I got a flow. But I can see the place of lesion. You can see in this caudal view, RAO caudal view. So I decided to put a stent right away in that segment. The stent was 3x28. I was in doubt whether stent, such a long stent, will go or not. So, but it went, and deployed at around 14 atmospheric pressure. RBP was 16. The length of stent is 28 into diameter 3. Then again inflated the stent at higher pressure 16, and this is the scene after stent deployment. See how long the LED is. It's almost wrap around the LED. That is why in lead 2-3 AVF also I was getting ST elevation in this patient. This was RAO caudal view. This was the iliocaudal view. And I felt there was some under deployment of the stent, under expansion. So I did the NC with the 3.5. And this is the picture after NC. You can see how long the LED is wraparound LED, which is supplying to large portion of heart. So this was the angioplasty to the LED after 5 days. The patient was stable